Okay, my name's Brianna, and I'm going to be doing the case study, trying to do the share the screen thing. Bear with me. Okay, so this is the case study that we're doing. So I'm just going to go through the questions. So since this patient has severe cardiomyopathy, and then the GI bleeding, so those are just the prominent issues with this patient. So for the first question, what may have precipitated his GI bleeding? Name two. Having severe dilated cardiomyopathy can cause changes in blood flow, which can cause functional changes in the GI tract, causing increased risk of GI bleed. Also, the patient is taking warfarin at home, and who knows how long he's been taking that for, so his blood is thinner and easier to bleed, so that once he starts a GI bleed, he'll just continue to have a GI bleed for a while. For number two, from his history and assessment, what signs and symptoms of GI bleeding and loss of blood volume does he have? Name at least 5 things and explain the pathophys for each one listed. So I said dark red blood, diarrhea or tarry stools, blood in the stool. That's what that is. He's also hypotensive. He's hypotensive because he's hypovolemic. No blood, like losing volume very quickly. So his body is trying to figure out how to compensate for that. And the third thing leads me to tachycardia, which is your body trying to compensate for the acute blood loss and hypovolemia. Number 4, he's dizzy. He's, again, losing volume. So he's not perfusing to his brain and all of that as well. So he's also pale from decreased blood circulation in the skin. Number 3, what is the most serious potential complication of his bleeding? He could die from hypovolemia. If left untreated, he could die. Number 4, your institution uses electronic charting based on the most recent assessment mentioned previously. Which of these systems would you mark as abnormal as you document your findings? So pretty much everything is abnormal for him. So neurologically, he's dizzy and slightly disoriented. Those are not normal. Respiratory-wise, his respiratory rate is 26. It's a little high. Again, compensation is happening. Cardiac, he has a murmur, he has trace pedal edema, and he has decreased capillary refill. GI, obviously the bleeding, but mid-epigastric tenderness and an enlarged liver. Musculoskeletal, he is weak, skin is pale. Psychological, he is anxious. And pain, he has like a 2 out of 10 pain. What intervention is required to assess his renal function? So to assess his renal function, they had mentioned that he has not voided since prior to coming to the hospital. So we would like him to void so you can test his urine. I mean, that's a good thing to do, but also they need to draw labs, check a BUN and creatinine on this patient. Number 6, calculating his MAP, mean arterial pressure, and why it's important. So in my hospital, we like MAP of 65 and above for most patients. So his MAP in this situation was 67. It is important because it's the average force of blood being perfused to the organs and body. And the lower the number, the less perfusion they're having. So these are the labs. Sodium is okay. Potassium is high. We don't like that. BUN and creatinine are elevated as well. White count, 16. Hemoglobin and hematocrit are a little low. PT and INR are prolonged. Examine the laboratory results and underline which one causes you the most concern. So for that, it would be the potassium. A K of 6.9 is very concerning because it can lead to fatal arrhythmias, and those could lead to death. So like ventricular arrhythmias, increased spike T waves. I'm sorry, I'm not used to recording, which is coming up. Number 8, in the view of previous lab results, which diagnostic tests will be performed and why? So they would do the EKG or ECG, which goes on to 9. They would do this to check for those fatal arrhythmias. In 9, his ECG strip is this. He has peak T waves, an early sign of elevated potassium, and in that he could quickly go from this to VTAC or another ventricular arrhythmia. 10, why do you think the BUN and creatinine are elevated? So they are probably elevated from decreased perfusion to the kidneys. A lot of this is perfusion issues with hypovolemia and blood shunting and all of that. What do the low hemoglobin and hematocrit levels indicate about the rapidity of his blood loss? They're pretty low, so he's losing blood fairly quickly. And if they need to replace it soon, considering what his heart rate and blood pressure look like. So he's definitely in acute hypovolemic shock. So they're going to need to replace some blood for him. What is the explanation for the prolonged PT-INR? This patient has been on warfarin for a while, who knows how long, but the point of that is to prolong those. So they would give like vitamin K to reverse that. 13, what will be your response to the prolonged PT-INR? Select all that apply. So we would A, hold the warfarin dose, B, avoid injections as much as possible. We would not do C, that will increase bleeding. We will definitely do D, we will monitor for signs and symptoms of bleeding. In E, we will not do that because instead we will do vitamin K. 14, what safety precautions would you initiate in light of his prolonged PT and INR? We would do bleeding precautions as well as neuro checks fairly frequently to make sure he's not going to have a brain bleed from those, as well as strict bed rest, because if the patient were to fall and hit their head, that would be a whole nother issue that they would have. We do not want. How do you explain the elevated white count? So that's probably from either a systemic infection or just from the hypovolemic shock. Everything is all messed up in the body at that time. So it could have just been from inflammation or just shock. 16, explain the purpose of FFP for him. So FFP, it gives back the coagulation factors that he probably lost from all the blood loss. So that is a good thing for them. We at our hospital, I work in the cardiac ICU, so we do a lot of MTPs. We give a lot of FFP, which is fresh flow frozen plasma. 17, calculate his fluid balance and identify whether it is positive or negative. So he is getting a lot more in than he is putting out. So he has net positive 4.838 liters, and that is very dangerous for a patient of his status, especially with a cardiac history, which kind of leads into 18. Why will you want to monitor his fluid status very carefully? Because of that, you don't want him going into flash pulmonary edema, or he'll become fluid overloaded very quickly. So it's important to watch for that. The 6 things you'll monitor to assess for his fluid balance are his intake output for the net positive, net negative, just to see where he's at. CVP and PA pressures, he's got that Swan-Ganz catheter, so that'll be easy for them to see. If they're elevated, that means his fluids are up, and if they're lower, he's more dry. You're going to want to weigh him daily at least to see if he's having changes in his weight, if he's having extreme weight loss or weight gain. That's important to know. And then just monitor for edema, lung sound, stuff like that for crackles. 20, list 5 things you might do to make the wife more comfortable while her husband is in the medical ICU. So a couple things you can do. You can just keep her updated, let her stay in the room with him if she's able to, and if she's calm. She might not want to be in the room while acute things are happening, but it's important to give her that option if she's able. Make sure she's eating and drinking, because sometimes they forget about themselves in these situations. Sometimes also it's nice for them to be able to do what they can for their significant other. So if they are able to help with the bathing, stuff like that, just to make sure that they feel like they're involved in his care and not just sitting watching everybody do everything for them. That's helpful. Also, if she wants to bring something from home, if he's able to eat and get maybe a little snack that's good for his diet, or like a blanket that's his from home that makes him more comfortable, stuff like that makes her feel like she's doing something, and that can help a lot. 21, what assessment findings would support that condition is improving? And we'll go through each one and see which one is effective, ineffective, or unrelated. So less drowsy and more alert, that's definitely effective. It means he's getting some more perfusion. Decreased blood pressure and increased heart rate. So that means what we're doing is not working because that's where we were at the beginning. Decreased PCWP, that is effective. Oral temperature, 98.9, that's effective. Urine output of 25 mLs an hour, that is ineffective. We should be doing at least 30, especially for that net positive. He needs to have more urine output. 5-pound weight loss in 24 hours. 5-pound weight loss, that's effective. That means we're losing water weight. But that's a lot of weight in 24 hours, but in his situation, we're okay with that. Bowel sounds present in all 4 quadrants. I would say that's unrelated because he probably has had bowel sounds throughout this whole thing. And bowel sounds present is a good thing. So after the transfusion, his blood pressure is 110/78 and pulse is 94. Respiratory rate is 18, much improved. Urine output is now 60 mLs an hour, which is much better. He's more alert, asked what happened, transferred to step down until the next day, and eventually transferred to rehab for a week of physical therapy before returning home. So all of those interventions helped, and he is much better. So there we go. I'm going to figure out how to pause this.